Hello, everyone. Welcome to the Green Top Guidelines Summary of the Day. We are here today to discuss the Green Top Guidelines 72, the care of the women with obesity in pregnancy, published in November year 2018. Obesity is becoming increasingly prevalent in UK population and has become one of the most commonly occurring risk factors in obstetric practice. With 21.3% of the antenatal population being obese and fewer than one half of the pregnant women, 47.3%, having a body mass index within the normal range. The prevalence of obesity in general population in UK has increased markedly since the early 1990s, and the prevalence of obesity in pregnancy has also been seen to increase, rising from 9 to 10% in the early 1990s to 16 to 19% in the 2000s. The classification of adults according to BMI, the classification of being underweight, normal range, overweight, pre-obese, obesity class 1, obesity class 2, obesity class 3 are very important for the exam. How do we do the pre-pregnancy care? The primary care services should ensure that all women of childbearing age have the opportunity to optimize their weight before pregnancy. Advice on weight and lifestyle should be given during preconception, counseling, or contraceptive consultations. Weight and BMI should be measured to encourage the women to optimize their weight before the pregnancy. Women should be informed that weight loss between pregnancies reduces the risk of stillbirth, hypertensive complications, and fetal macrosomia. Weight loss increases the chances of successful vaginal birth after cesarean section. Women of childbearing age with a BMI of 30 kilogram per meter square or greater should receive information and advice about the risks of obesity during pregnancy and childbirth and be supported to lose weight before conception and between pregnancies in line with the NICE guideline. Women with BMI 30 kilogram per meter square or greater wishing to become pregnant should be advised to take 5 milligram folic acid supplementation daily, starting at least 1 month prior to the conception and continuing during the first trimester of the pregnancy. Obese women are at high risk of vitamin D deficiency. However, although vitamin D supplementation may ensure that women are vitamin D replete, the evidence on whether routine vitamin D should be given to improve the maternal and offspring outcomes remains uncertain. Care of women with obesity in pregnancy can be integrated into all antenatal clinics with clear local policies and guidelines for care available. All maternity units should have a documented environmental risk assessment as well. The risk assessment including the circulation space, accessibility including the doorway widths and thresholds, safe working loads of equipment and floors, appropriate theater gowns, equipment storage. The transportation, staffing levels, availability of and procurement process for specific equipment including large blood pressure cuffs, appropriately sized compression stockings and pneumatic compression devices, sit-on weighing scale, large chairs without arms, large wheelchairs, ultrasound scan couches, ward and delivery beds, mattresses, theater trolleys, operating theater tables, and lifting and lateral transfer equipment. Maternity units should have a central list of all facilities and equipment required to provide the safe care to pregnant women with a booking BMI 30 kilogram per meter square or greater. Some women with a booking BMI less than 40 kilogram per meter square or greater may also benefit from assessment of moving and handling the requirements in the third trimester. This should be decided on an individual basis. Women with a booking BMI 40 kilogram per meter square for whom moving and handling are likely to prove unusually difficult should have a moving and handling risk assessment carried out in the third trimester of pregnancy to determine any requirements for labor and birth. Clear communication of manual handling requirements should occur between the labor and theater suites when women are in early labor. All pregnant women should have their weight and height measured using appropriate equipment and their BMI calculated at the antenatal booking visit. The measurements should be recorded in the handheld notes and electronic patient information system. For women with obesity in pregnancy, consideration should be given to reweighing the women during the third trimester to allow appropriate plans to be made for equipment and personnel required during labor and birth. There's a lack of consensus on optimal gestational weight gain until further evidence is available. A focus on a healthy diet may be more applicable than prescribed weight gain targets. So they should know with a booking or greater BMI of 30 kilogram per meter square that they have accurate and accessible information about the risks in the pregnancy. The diet advised by an appropriately trained professional should be provided early in the pregnancy. Anti-obesity or weight loss drugs are not recommended for use in the pregnancy. The pregnant women with a booking BMI 40 kilogram per meter square or greater should be referred to an obstetric anesthetist for consideration of antenatal assessment. Difficulties with venous access and regional and general anesthesia should be assessed. In addition, an anesthetic management plan for labor and birth should be discussed and documented. Multidisciplinary discussion and planning should occur where significant potential difficulties are identified. Women with a booking BMI 40 kilogram per meter square or greater should have a documented risk assessment in the third trimester of pregnancy by an appropriately qualified professional to consider tissue viability issues. This should involve the use of a validated scale to support the clinical judgment. The clinicians should be aware that women with class 2 obesity and greater have an increased risk of preeclampsia compared with those with a normal BMI. All pregnant women with a booking BMI 30 kilogram per meter square or greater should be screened for gestational diabetes according to NICE or Scottish Intercollegiate Guidelines Network. An appropriate size of cuff should be used for blood pressure measurements taken at the booking visit and all subsequent antenatal consultations. Women with more than one moderate risk factor, that is BMI of 35 kilogram per meter square or greater, first pregnancy, maternal age of more than 40 years, family history of preeclampsia, multiple pregnancies, they may benefit from taking 150 milligram aspirin daily from 12 weeks of gestation until the birth of the baby. Women who develop hypertensive complications should be managed according to the NICE guideline we have discussed earlier in the live session as well. The venous thromboembolism undoubtedly is a very important risk factor and very important exam question as well. Therefore, we need to score the patient if the BMI is 30 kilogram per meter square or if it's 40 kilogram per meter square. The risk assessment has to be done individually. Documentation needs to be done in that situation. And the Green Top Guideline 37A needs to be followed for venous thromboembolism prophylaxis. Women with BMI 30 kilogram per meter square or greater are at increased risk of mental health problems and should therefore be screened for these in pregnancy. There is insufficient evidence to recommend a specific lifestyle intervention to prevent the depression and anxiety. All women should be offered antenatal screening for chromosomal anomalies. Women should be counseled that some forms of screening of chromosomal anomalies are slightly less effective with raised BMI. We consider the use of transvaginal ultrasound in women in whom it is difficult to obtain knuckle translucency measurements transabdominally. Screening and diagnostic tests for structural anomalies, despite their limitations in the obese population, should be offered. However, women should be counseled that all forms of screening for structural anomalies are more limited in obese pregnant women. The table 2 of the Green Top Guideline, the risk of the fetal structural anomalies for obese pregnant women, structural anomalies and their odds ratio with the confidence interval. Please have a look. As recommended by RCOG, Green Top Guideline number 31, the serial measurement of the symphysis fundal height is recommended at each antenatal appointment from 24 weeks of gestation, as this improves the prediction of small for gestational age fetus. Women with BMI greater than 35 kilogram per meter square are more likely to have inaccurate symphysiofundal height measurements and should be referred for serial assessment of fetal size using ultrasound. where external palpation is technically difficult or impossible to assess the fetal presentation. Ultrasound can be considered as an alternative or complementary method. In the absence of good quality evidence, intrapartum fetal monitoring for obese women in labor should be provided in accordance with the NICE guideline. There's a lack of definitive data to recommend the routine monitoring of post-stage pregnancy. However, obese pregnant women should be made aware that they are at increased risk of the stillbirth. Women with maternal obesity should have an informed discussion with their obstetrician and anesthetist about a plan for labor and birth, which should be documented in their antenatal notes. Women who are multiparous and otherwise low risk can be offered choice of setting for planning their birth in midwifery-led units with clear referral pathways for early recourse to consultant-led units if complications arise. Active management of the third stage should be recommended to reduce the risk of the postpartum hemorrhage. Elective induction of labor at term in obese women may reduce the chance of cesarean birth without increasing the risk of the adverse outcomes. The option of the induction should be discussed with each woman on an individual basis. Women with a booking BMI 30 kilogram per meter square or greater should have an individualized decision for VBAC following an informed decision and consideration of the clinical factors. The class 1 and 2 maternal obesity is not a reason, I repeat, is not a reason in itself for advising the birth with consultant-led unit, but indicates that further consideration of birth settings may be required. The additional intrapartum risks of maternal obesity and the additional care that can be provided in consultant-led unit should be discussed with the woman so that she can make an informed choice about planned place of birth. The on-duty anesthetist covering the labor ward should be informed of all women with class 3 obesity admitted to the labor ward for birth. Women with class 3 obesity who are in established labor should receive continuous midwifery care with consideration of additional measures to prevent the pressure sores and monitor the fetal condition. Women with BMI 40 and more should have venous access established early in labor, and consideration should be given to the siting of a second cannula. Although active management of the third stage of labor is advised for all women, the increased risk of postpartum hemorrhage in those with a BMI greater than 30 kilogram per meter square makes this even more important. There is a paucity of high quality evidence to support the use of one surgical approach over another. Women with class 1 obesity or greater having a cesarean section are at increased risk of wound infection and should receive prophylactic antibiotics at the time of the surgery, a very important exam question. Obesity is associated with low breastfeeding initiation and maintenance rates. So, BMI 30 kilogram per meter square or greater should receive appropriate specialist advice and support antenatally and postnatally regarding the benefits, initiating and maintaining the breastfeeding. Women who have been diagnosed with gestational diabetes are basically managed as per NICE guideline, and they're supported to lose weight postpartum and offered referral to the weight management services where these are available. A minimum waiting period of 12 to 18 months after bariatric surgery is recommended before attempting the pregnancy to allow stabilization of body weight, to allow the correct identification and treatment of any possible nutritional deficiencies that may not be evident during the first months. Women with previous bariatric surgery have high risk of pregnancies and should have consultant-led antenatal care. Women with previous bariatric surgery should have nutritional surveillance and screening for deficiencies during pregnancy. Women with previous bariatric surgery should be referred to a dietitian for advice with regards to their specialized nutritional needs. Some important exam points from the Green Top guideline are the classification of obesity, important single-based answer. Please do not forget the indications of 5 milligram folic acid. That's a must question for your exam. The antenatal intrapartum care for the obesity and specifically the venous thromboembolism associated with the BMI. Best of luck from the entire team of RFA tutors. Thank you very much for being with us today. See you next time with the next Green Top guidelines summary. Until we meet again, bye-bye. Thank you.